Welcome to this explainer on pulpotomy. If you're gearing up for your pediatric rotations or maybe teaching over at the dental college, you already know that saving a kid's tooth is about way more than just a quick fix. Today, we're going to unpack the essential clinical guidelines and vital pulp therapy protocols to give you exactly what you need for the clinic floor. We'll be breaking down the biological rationale, your step-by-step clinical playbook, and the modern materials that actually make this procedure so incredibly successful. Okay, let's dive right into our roadmap for today. We've got 6 main sections we're going to hit. First, an introduction to pulpotomy, then indications and rationale. After that, we'll go through the step-by-step procedure, check out modern pulpotomy materials, look at the advantages and success criteria, and finally wrap up with conclusion and takeaways. All right, Section 1, Introduction to Pulpotomy. Let's establish the exact baseline of what we're actually trying to achieve when that pediatric patient sits down in your chair. So the crucial thing to remember here is that a pulpotomy is a vital pulp therapy. Unlike a pulpectomy, where you're taking out the entire pulp from the crown and the roots, your primary goal here is to carefully amputate only the diseased coronal tissue. The whole biological principle we're relying on is that the radicular pulp, the stuff down in the roots, is still completely healthy and perfectly capable of healing once we get rid of that infected coronal portion. And what's fascinating is that your therapeutic objective actually shifts depending on the specific tooth you're working on. If it's a primary molar, you're mostly trying to keep that tooth functioning as a natural space maintainer, right? Just to prevent crowding and malocclusion down the line. But if you're dealing with a young, immature, permanent tooth, your main goal is apexogenesis. You want to keep that radicular pulp alive so the root apex can naturally keep developing and eventually close. Moving on to Section 2, Indications and Rationale. Because honestly, your clinical judgment here is going to be the ultimate deciding factor between a massive success and a complete clinical failure. You'll want to keep this mental checklist handy every single time you do an exam. A pulpotomy is strictly indicated only when the inflammation is confined right to that coronal pulp. So, you're looking for a tooth with a carious or mechanical exposure, but the patient needs to be asymptomatic, or at worst, maybe having reversible pulpitis with that provoked short-lasting pain. The tooth absolutely must be restorable, no pathologic mobility, and this is huge, once you're actually in there, the bleeding has to be controllable within just a few minutes. On the flip side, here's when you need to hit the brakes. If the patient is reporting spontaneous pain, or maybe pain that's literally waking them up at night, massive red flag. If you see swelling, a sinus tract, purulent discharge, or if you're looking at your radiograph and spotting internal root resorption or furcation radiolucency, you have to abort the pulpotomy right then and there. Those are clear-cut signs of irreversible pulpitis or necrosis. At that point, you've got to pivot to a pulpectomy or just extract the tooth entirely. Okay, Section 3, Step-by-step procedure. Let's walk through the exact sequence you're going to follow on the clinic floor. Think of this as your operational playbook. You start with your diagnosis and profound local anesthesia. Step 2 is absolutely critical, the rubber dam. Honestly, isolation is just non-negotiable here to maintain an aseptic field and keep out salivary contamination. Then you'll remove the caries and completely unroof the pulp chamber. Step 3 is cleanly amputating that coronal tissue right down to the canal orifices using a high-speed burr or a really sharp spoon excavator. After that, you establish hemostasis, place your chosen medicament over the radicular stumps, drop in a base like glass ionomer, and finish it off with a permanent restoration. I really want to pause on Step 4 for a second, because you can never, ever forget this golden rule during hemorrhage control. When you place that sterile, moist cotton pellet over the pulp stumps with a bit of gentle pressure, you need to see hemostasis within 3 to 5 minutes. If you pull that pellet away and see profuse, dark blood that just will not stop, it means the radicular pulp is already infected. You simply cannot proceed with a pulpotomy. You have to switch gears to a pulpectomy. And then, of course, your final restoration is paramount. Once that medicament is down, immediate placement of a leak-proof restoration is totally vital. For primary molars, the absolute gold standard here is a stainless steel crown. Getting proper adaptation and cementation of an SSC gives you this incredible hermetic seal that prevents bacterial microleakage, which honestly is what secures the long-term success of everything you literally just did underneath it. All right, Section 4, Modern Pulpotomy Materials. Now that we've got the technique down, let's explore your clinical arsenal and take a look at the specific materials you'll be using over those radicular pulp stumps. When we look at the evolution of our medicaments, there's a really stark contrast. Historically, we relied heavily on Buckley's formicrosol, which essentially just fixes or mummifies the tissue. Then we have ferric sulfate, which acts primarily as a hemostatic agent forming an iron protein complex. But check out the bottom two, MTA and biodentine. This really highlights the massive leap we've made from those older fixatives to the regenerative power of modern bioceramics. These silicate-based materials are completely biocompatible, and they actually stimulate hard tissue, a dentin bridge, to form. They promote true biological healing. So, for decades, Formocresol was the absolute go-to material in pediatric dentistry. But as modern clinicians, we kind of have to ask, why is it so rapidly falling out of favor in university clinics and private practices alike? Well, the sources clearly show that the evidence-based consensus has majorly shifted. The AAPD, the American Academy of Pediatric Dentistry, their guidelines advocate moving away from Formocresol due to some pretty well-documented concerns regarding cytotoxicity, mutagenicity, and systemic distribution. The whole field has shifted heavily toward these safer, bioactive materials. MTA and biodentin are firmly established as the gold standard now, simply because they don't just temporarily mask the problem, they actively promote a really healthy biological response. Moving into Section 5, Advantages and Success. Let's see how all of this builds our understanding of why this procedure is still such a cornerstone of pediatric dentistry, and what clinical success actually looks like. The advantages here are massive. First off, it's a highly conservative approach compared to jumping straight to pulpectomies or extractions. By keeping the tooth alive and functional, you are actively maintaining arch length and sparing that child from some incredibly complex, expensive orthodontic interventions or space maintainers later on. Plus, it's a single-visit, child-friendly procedure. And when you utilize modern bioceramics like MTA, the literature shows these incredible success rates, usually hovering right between 90 and 100%. But how do you actually know if it worked? Well, you'll know your procedure was a triumph through rigorous follow-ups, typically at the 6 and 12-month marks. Clinically, that tooth should be totally functional with zero pain or swelling. Radiographically, you want to see a perfectly normal PDL space, absolutely zero signs of pathological internal or external root resorption, and no periapical or furcation radiolucency. And if it's a young permanent tooth, you should actively be seeing that root continue to develop. Finally, Section 6, Conclusion and Takeaways. As we wrap up this explainer, let's distill all of this down to the core philosophy you need to carry with you right onto the clinic floor. If you take away just one thing from all of this, let it be this. Strict case selection and maintaining an aseptic chain are the true cornerstones of a predictable, successful pulpotomy. Your ability to correctly diagnose the state of that pulp, really differentiating between reversible and irreversible pulpitis, and then meticulously executing the procedure with a rubber dam and modern bioceramics, that is what will empower you to confidently save teeth that would otherwise be completely lost. And as we look to the horizon, it is an incredibly exciting time to be entering the field of pediatric dentistry. With autologous materials like platelet-rich fibrin showing really promising results, and dental pulp stem cell research advancing as fast as it is, regenerative therapies are just constantly evolving. It makes you wonder, what will the future of vital pulp therapy look like in the next decade? Will we eventually move beyond amputation entirely and just regenerate the whole thing? I'll leave you to think about that. Thanks for joining me on this explainer, and good luck out there in the clinic.